I'm going to summarise things here really now. What I've put here is essentially, I think all of us have been talking about the patient. We've got the patient at the centre of everything. That was very clear with what Richard said there. And we've had Malcolm talk about HIPEC. You're going to hear Sekar talking later on, Mr. Silva Sekar, about the robot. There's lots of new initiatives at the Christie in surgery. Radiotherapy, you've heard new techniques from David, and particularly the protons, which will be starting at the Christie soon. We then have, what I'm going to mention very briefly in a minute, is the molecular biology side and chemotherapy side with targeted drugs and personalised treatments. Supportive care from diagnosis, I think that's the thing really, rather than just end-of-life treatment. Patient monitoring, I mean, technology is coming in everywhere. And I think if you put all those together, there's arrows everywhere. And I think that's, we do link very closely, either by the phone, by MDTs, that is the real big thing at the Christie. It's very easy to get everybody working together. And I think that happens in a lot of hospitals as well. There's many other specialities I've never mentioned here. We only had 75 minutes, so you could have the radiologists, the pathologists, nurses, physios. They're crucial in all of this. So I'm going to really, we've only got a few minutes. I know we lost a bit of time at the beginning with all the introductions, so I'm going to just really go on, if you don't mind, for about 5 minutes. We've got the antibodies, first of all. You know, with chemotherapy, essentially it makes people hopefully better, but also very unwell with it. And so there's much more targeted treatments now to try and cause less side effects to the patient and provide efficacy as well. Now, the antibodies, essentially, they attack the cell surface. They will bind to a receptor on the cell surface and cause their changes inside. And the names you might hear of is things like bevacizumab or Avastin, which attack the cell surface of a cell and reduce the amount of angiogenesis, amount of new blood vessels forming. You've got things like cetuximab that will slow cancers down by binding to the growth factor receptor on the cell surface. There's even newer ones. As I said, we give chemotherapies that often, you do wonder, they make people poorly. You might get people like Richard that make people a bit better with it. But there's this drug here, it's a new one out, an interleukin-1 alpha inhibitor. And what that does, it makes people feel better. And we've got quite a number of patients on it in a trial, and people cope really well with it. They actually do feel better. They've been left breathless with it, more mobile, and it seems really odd that actually you give a drug to make people feel better, and they actually live longer with it. By making you better, you live longer. So it's a new way of looking at things. There's also the tyrosine kinase inhibitors. And essentially another complicated looking slide, and what it shows there is the outside of the surface where all the antibodies bind to, and you've got the inside of the cell membrane there. And the tyrosine kinase inhibitors, they attach there and work in that way. And there's a whole range of new drugs out that have slightly different side effects, but often less side effects than the main ones that we've used for a long time. We've used one in a trial called the Dream Therapy trial, where we've added it to radiotherapy, this new vascular endothelial growth factor inhibitor, a simple tablet that we add to it, and we find that the benefits from radiotherapy are greatly increased, and this is going into a much larger trial. So it's adding a small tablet, causes very few side effects, and it does seem to have actually had a great deal of increase in efficacy. There's also the circulating tumour cells. You can measure these in patients, in a cancer patient that comes along. You can take a blood sample, 7.5 mils, and you can work out, see the number of tumour cells in a patient. And in colorectal cancer, if you've got none, you do better. If you've got 3 or more, you do dreadfully. I mean, it's whether, do you do these things? Would you like, as a patient, to know your tumour cell number? I think unless you can do something about it, you really wouldn't want to know, really. So what we were setting up at the Christie is to try and give a more intensive treatment to people with high tumour cells, and a less intensive treatment to people with fewer tumour cells in the blood. And what we did show is that the patients that had the more intensive treatment actually did do better if you gave that to people that had a poor prognosis, had a lot of these tumour cells. Now, what I put here is that tumours are made up of many different cells. I mean, that's perhaps pretty obvious, but there was a great paper from a guy called, well, it's Gerlinger is the first author, but it's Charlie Swanton was the main author on it, and essentially they biopsied numerous different areas on the same tumour. And what they found is the mutations were different in every place. So how many times do you biopsy? Because actually they biopsied 10 times and they got mutations are different. So each tumour is really different. There's also post-mortem studies, and they show, if you look here as a stylised way, the primary tumour have a certain number of cells. The metastases may have a completely different cell group with completely different mutations in it. And what people have done with post-mortem studies, when patients will donate their body at death, and then they have an operation to get multiple biopsies, you can see where the cancer spreads from one place to another place. You can actually almost predict which way it's gone through the mutations that are developing through the tumour. And these are some of the tumour cells here. You can see the black are the holes in like a template that they're put on, and these are the tumour cells here, and they're going through the pores there. So they've a whole cluster of tumour cells that you can find in the blood. Even easier is circulating free DNA. You can find loads of that in blood from patients with metastatic colorectal cancer and other cancers. And we had a study called the COBRA trial, where we looked at the amount of a particular mutation called the RAS mutation, and we found it in the circulating free DNA in the blood. Normally we had to take a sample from the tumour to find that out, but now we can just take a blood sample and we can find out their RAS mutations. It then means that it's easy for the patient. Blood sample's easier than going to get a biopsy. It also means that we can look for their mutations as they go along. They can have one every 3 months. You could then see the different mutations, and then when the newer drugs are coming out, you can perhaps change the therapy because the mutations that are developing in the blood as patients go along, which is a lot easier than constantly getting biopsies. There's a trial at the Christie led by an excellent, really unit at the Christie, the phase 1 unit, and Matt Krebs is the senior author here, when essentially we are looking at the tumour samples, but we're looking at sequential blood samples to look at mutations, and they've got now a whole battery of new drugs that have come out that work on particular mutations in cancers. And so what you hope is, in the long run, is that you'll take a blood sample, you look at the circulating free DNA, you'll see so many mutations, you say, well, I want that, that drug should be better for you. Now, we're not there in some cancers yet, but we're getting very near there. Certainly, I would say in 5 years, we'll be much more looking at that way. And this is the sort of trials that are really proving it. What about immune therapies? It's every patient that comes to see me says, I want an immune therapy. That seems to be the new thing. There's always some fad that comes out. And for people with melanoma, it isn't just a fad, it is great. Melanoma, obviously the mould you get with sun-exposed tissue, it was a dreadful illness for metastatic disease, it's absolutely foul. With immune therapies, it's made a huge difference. They're very expensive, these drugs, but NICE have recognised actually they are good. They're very expensive, but actually they are cost effective. They actually do provide a benefit for patients. And this is really, again, a stylised picture, but what they essentially do, they activate the body's tumour cells, T cells, the white cells, the T cells, to attack the tumour. Normally they're sort of down-regulated, putting it simply, in patients with cancer, and so they bring up the T cells again, the white cells, to attack the cancers. We've got a study called the Modals trial at the Christie, which does exactly that. We get biopsies of patients, look for mutations. If they have one particular mutation, they'll go on to receive this particular combination. If they have other mutations, they go on to get these different drugs with these different immune therapies. So again, we're trying it out with these new agents. So we've got all these people, we've got the surgeons, the supportive care, the chemotherapy, radiotherapies, all the other specialities, all centred on the patient, trying to help that patient. And I think what we have shown is that there are many advances, you've seen them all here today, that I think they have resulted in better care for patients, either less side effects, better survival. I think we've all got to think, can we afford them? I think if you look at a colorectal cancer patient that perhaps median survival was 6 to 9 months without any chemotherapy, they're now living up to 3 years. Don't sound much, but it's a lot better than 6 to 9 months. But to get to them to that 3 years, that could cost about £50,000 for every patient. And when you think there's 40,000 patients with colorectal cancer per year, and about half will get metastatic disease, that's a colossal number of patients that will end up having very expensive treatment. So I hope you've enjoyed today. It's a snapshot of what we're doing at the Christie, which is sort of really leading the way, I think, in a lot of different surgical techniques, radiotherapy, chemotherapy, supportive care. So thank you very much for staying and listening to us. Thank you.